Welcome guys to this Harrison based chapter discussion module videos. It is based on the newest edition, 22nd edition, and today we are going to cover an important topic, altitude illness. Why it is important? Because this topic has been asked repeatedly in this recent exam, particularly if we check the NEET-SS paper of 2025. Around 25 to 30 odd question was almost asked from environmental medicine, making this topic very much important for upcoming exams too. So coming to it, these are completely Harrison based note, simple note, easy revisable one with important points marked in it. So we're going to discuss this one from the chapter. So first thing, what is altitude illness? Altitude illness is a spectrum due to hypobaric hypoxia. Okay, there are a lot of diseases which comes into this topic, but key pathophysiology, if you ask me, is nothing but hypobaric hypoxia. What does it mean? It is a condition when as partial pressure of oxygen, partial pressure of oxygen at high altitude is low. As high altitude is low, therefore, although air contains 21% of oxygen, but the diffusible oxygen in the alveoli or the artery, that is PaO2 or PaO2, is low. It remains low. It remains low, resulting into state of hypoxia, more of a hypoxia in which hypoxia is at the low oxygen at the tissue level, which you call it to be a hypoxemic hypoxia. Okay, all right. Now, this altitude illness can be divided into three types. Okay, main three types. There are other two, but these are the three important subtypes of altitude illness that we need to study. The first thing is acute mountain sickness, so which you call by the name of AMS, is our acute mountain sickness. Then we have high altitude cerebral edema. So this acute mountain sickness and high altitude cerebral edema both are having CNS manifestation, but acute mountain sickness will be mild to moderate in intensity, whereas HACE is very severe in intensity. All right. As HACE is very severe intensity, this AMS and HACE can be considered disease of the same spectrum only. So this HACE is nothing but disease of the same spectrum, same pathophysiology, but on the extreme end, a very serious end. And HAPE or high altitude related pulmonary edema, which is nothing but non-cardiogenic edema, non-cardiogenic edema. So this HAPE will have different pathophysiology compared to AMS, HACE, AMS and HACE. Okay. Now, coming to some of the epidemiology related question that can be asked, it is from Harrison only. So, if you see the trackers who go up, among them, 50% who ascend more than 4,000 meters over 5 days will develop acute mountain sickness. Okay, that's the dictum. 50% of the trekkers who ascend above the 4,000 meter or above 4 kilometer within more than 5 days, 5 or more days, they develop into acute mountain sickness. So it is very much common. And rapid ascent, for example, 3,500 to 4,000 meter will lead to AMS or acute mountain sickness in around 80% of case. So you can see acute mountain sickness is very common disease spectrum. Okay. Now, but whether if you look into the incidence of HACE versus HAPE, it is very low around the range of 0.1 to 0.4%. So what does this epidemiological data represent? This epidemiological data represents that although HACE and HAPE incidence is low, but it is very much fatal. It's very much fatal and it becomes the cause of death. Now, remember, in AMS and HACE, there is no predilection from particular gender getting affected, whereas gender different is seen in HAPE. HAPE is more common in male compared to female. Okay. Now there is one thing known as re-entry HAPE. What is it? It occurs in Highlanders who return from the low altitude. When does it occur? Suppose someone someone from very high altitude, say Himalayas or the Tibet, who went in the downstream in the low altitude region. They were there for more than 5 to 10 days or 11 to 12 days, and when they go back to their native place, then they develop the similar symptom of high altitude illness. This high altitude illness, which is commonly seen in the who were original descendants of high altitude, is known as re-entry HAPE. Okay, so this is known as re-entry HAPE. Now, let's come into the physiology of altitude exposure. Coming to this, you can see, so there is decrease in barometric pressure, decrease in partial pressure of oxygen, resulting into hypoxemic hypoxemia. At the meantime, I can ask you a question: what are the types of hypoxia? So hypoxia means decrease in oxygen at the tissue level for any cause. It can be hypoxemic. So hypoxemic is the condition when the oxygen total delivery load is low. So it can be due to this high altitude, that condition which we are studying, or it can be due to the condition of lung pathology, say pneumonia, when the lung cannot take enough oxygen from the air, external air, and pass into the blood, so that the tissue can get enough of oxygen. So pathology, any part of the lung, or which any disease, better to say for MCQ purpose, VQ mismatch, will result into hypoxemic hypoxemia or hypoxia. Now, hypoxia can also be there due to anemia, which is known as anemic hypoxia. Why so? Because hemoglobin is the sole carrier of oxygen in most of the cases. Due to decrease in hemoglobin content, as the oxygen carrying capacity is decreased, therefore oxygen delivery at the tissue decreases. That's why in case of anemia, for any reason, any form of anemia, there will be some sort of hypoxia or respiratory illness related symptoms in anemic patient. This is known as anemic hypoxia. Then there is another form which is known as stagnant hypoxia. So here blood is enough, blood is adequate, here oxygen delivery load is enough, stagnant hypoxia. But what is the issue? Issue here is the delivery of blood to the tissue is not working. When does it occur? When there is cardiac failure, so output from the heart is low, or when there is a case of shock. At this cases, delivery at the level of the tissue will be low. Okay. Now, again, although if the delivery is there adequate, but still there can be some case when cell cannot utilize it. When does it occur? When the electron transport chain itself is getting hampered. Okay. So, for example, as in case of cyanide poisoning, cytochrome Q of electron transport chains get affected, resulting into form of hypoxia, which is known as histotoxic hypoxia, because of the toxic element, right? So from here, hypoxia can be divided into 4 types, very important for MCQ and very important for your question. But remember which is the most common type? Most common type for us to be hypoxemic hypoxia, and the disease which we are dealing now is high altitude illness. In high altitude illness to hypoxic hypoxemia can be seen. Okay. Now coming to the notes from the Harrison, as you can see, so primary trigger is decrease in barometric pressure, and decrease in barometric pressure resulting into decrease in partial pressure of oxygen and hypoxemic hypoxia. Now, what will be our body's response to this hypoxia? Our body will immediately start increase in the ventilatory response, because our carotid body are getting stimulated by decrease in partial pressure of oxygen or due to hypoxia. So there is increase in ventilatory response, and there will be tachypnea, which may lead to even respiratory alkalosis, or the condition is known as CO2 washout. Okay. Now, At this point, this CO2 washout or respiratory alkalosis is the method in which our body is trying to maintain oxygen content in the blood. So if respiratory alkalosis is adequate enough, this pathophysiology or mechanism of high altitude illness can be reversed. All right. So how the body will acclimatize or how the body will maintain the condition? It will correct the alkalosis by excreting bicarbonate. From where? From the kidney. Renal bicarbonate excretion will increase and it will cause metabolic acidosis to correct the alkalosis part so that the pH remains balanced. There is no symptoms of acidemia or alkalemia, anything, and the body tries to restore the balance by maintaining CO2 washout. Okay. Again, in case of chronic cases, erythropoietin synthesis will increase. EPO synthesis will increase. Okay. So this will lead to increased production of hemoglobin, as hemoglobin is the carrier of oxygen. So due to increase in hemoglobin, erythropoietin increases and it helps in increasing load of oxygen to the tissue. Now, due to hypoxia, there is shift of rapid flavoring cycle towards increasing 2,3 BPG. As 2,3 BPG increases, it increases oxygen delivery at the tissues too. So these are the all the physiological changes that helps in acclimatization, and these are the points from which question can be asked. So few things that I want you to know is that some point. Remember, for each patient or even each mountain climbers, excess capacity decreases 1% per 1000 meter above 1500 meter. So once they climb above 1500 meter, the exercise capacity will decrease by 1%. And obviously, when ascent and acclimatization does not go hand in hand, so there is a balance between ascent and acclimatization. When ascent is more compared to the acclimatization, it will result into condition of illness. Okay. So some potential future question which can be asked, it can be asked from the topic of genetics. So remember, in all cases of hypoxia inducible factor pathway gets activated and resulting into increase in erythropoiesis and hemoglobin, or better to say RBC synthesis. Okay. But it has been found strangely in Tibetan population that they have lower hemoglobin despite hypoxia. So main mechanism has been found out due to mutation in a gene which Tibetan population is found to have been with them is APAS1 mutation, APAS1 gene mutation, which is thought to have central role in them, in for which they have low hemoglobin despite of hypoxia. Why so? It is a natural mechanism so that they can be prevented from polycythemia and polycythemia related complication. Okay. Okay. Now, beside APAS1, recently few more genes has been discovered. These are EGLN1 and PPIRA. Okay. So these are implicated in this pathophysiology. So how does you explain this? How do you explain this? You can explain by familial clustering method or peripheral risks despite the similar exposure. Now, coming to the specific disease. First of all, we are going to talk about acute mountain sickness, which can be mild to moderate. Remember, acute mountain sickness or even this high altitude related cerebral edema, both are having CNS manifestation only. Okay. But milder symptom will be seen in acute mountain sickness. So what will be seen in acute mountain sickness? There will be headache, there will be nausea, vomiting, fatigue, dizziness, and disturbance of sleep. Okay. Now, this onset usually occurs within 6 to 12 hours, within 6 hours to 12 hours. Okay. It occurs within 6 hours to 12 hours 12 hours of ascent in case of acute mountain sickness. All right. Now, diagnosis of acute mountain sickness is completely clinical. Remember this part. Although Lake-Lewis score has been devised, Lake-Lewis score is nothing but is used for research purpose, for study designs only. Okay. So diagnosis is completely clinical based on the history of ascent, mountain climbing, and which is developed symptom around 4 to 5 hours of climbing, a particular duration above which this symptom is occurred, and symptoms are usually neurological symptom but mild and moderate variety. It can be dizziness, it can be vomiting, it can be nausea, it can be sleep disturbance. Okay. Now remember, this acute mountain sickness should be distinguished from other causes like exhaustion. Exhaustion. It can be due to dehydration, hypothermia, alcoholic hangover, or hyponatremia have similar set of symptoms too. That's why these are the important differential and it needs to be distinguished from them. Now coming to high altitude cerebral edema. So if you look into the concept, so this is nothing but severe end of acute mountain sickness spectrum. Okay. Now they have encephalopathy. They have encephalopathy. Now, if you look into the clinical feature, what are the serious symptoms that can be seen in cerebral edema? Two things I need you to know. One, there will be no focal neurological deficit. So no focal symptom. No focal symptom. All the symptom will be generalized. Okay. Okay, no focal symptom, all the focal symptom generalized. And what is the hallmark? Hallmark is ataxia. So there will be movement disorder in them in case of high altitude cerebral edema. Even if you forget, remember it is cerebral. As it is a cerebral, obviously ataxia will be there. What else? What else? There will be altered sensorium, there will be confusion, coma, there will be papilledema, and papilledema, remember, very important for exam. If papilledema sets in, it is very late finding. It is not the early finding, it is very late finding. Sometimes, if someone rose up 5,000 meters, there can be retinal hemorrhages too. Okay. Now, important part of high altitude cerebral edema is that again hypoxia mediated cerebral vasodilatation. Okay, hypoxia mediated cerebral vasodilatation, which leads to vasogenic edema. So again, coming to this part, if you check cerebral edema, it can be vasogenic edema, then it can be interstitial edema, or it can be cytotoxic edema. So what are those types and variety? All course lies in the fact that in cerebral edema there will be swelling. Okay, there should be swelling and it will lead to these symptoms. So in cytotoxic edema, swelling lies despite of normal blood-brain barrier. So blood-brain barrier function remains normal. Swelling lies because of effect at the level of inside the cell, in which oxygen delivery at the tissue level is disrupted. So ATP synthesis decreases, or ATP inside the cell decreases. So ATP dependent ion channel like sodium potassium ion channel gets hampered and leads to water accumulation. Water accumulation. So this is known as cytotoxic edema. In vasogenic edema, as in this case, there is cerebral vasodilatation. Cerebral vasodilatation leads to increased vascular endothelial growth factor mediated increase in nitric oxide, mediated injury to the blood-brain barrier, and resulting into permeability. So in this case, blood-brain barrier is getting hampered and resulting into increase in permeability. Okay. So all of this gets leads to edema, and interstitial edema is seen in case of hydrocephalus. So if I want to give you example of these cases, cytotoxic will be seen when there will be ATP decrease inside the tissue level. So when there is decrease in oxygen supply, as in case of ischemia. All right. Even in case of meningitis, whole brain is getting affected, it will lead to cytotoxic edema. Okay. Vasogenic edema will be seen in obviously in case of hypoxia mediated injury, that is high altitude cerebral edema topic we're studying. It can occur due to even brain tumors. Okay. Brain tumors or meningiomas. Okay. All right. Now, coming to this pathophysiology of high altitude cerebral edema, you see there is vasogenic edema at the iliac phase and mostly in the splenium region of the corpus callosum. Even in the MRI, you can see splenium to be hyperdense. Okay, it to be hyperdense because of the edema. Oh, And in severe cases at end stage, obviously, vasogenic edema can lead to cytotoxic edema too. So as you can see, there is marked swelling and hyperintense posterior body and splenia of the corpus callosum with high density, and this patient whose MRI was given actually suffered from HACE, but even after suffering, after recovery, after 9 months, they again went for climbing. Okay, so it is not something that is not reversible. It can be reversible with adequate treatment. Now, coming to the third of the disease for us, that is high altitude pulmonary edema. So remember, this is a form of non-cardiogenic pulmonary edema. Now, it occurs late compared to HACE or AMS. It occurs around 2 to 5 days after arrival. Okay. So it is not always preceded by AMS. So it is not something that AMS was going into HACE, but it is not sure patient can independently develop HAPE. Or sometimes AMS can lead to even HAPE too. And even these three things can go hand in hand together. What is the risk factor? Obviously, rapid ascent, prior HAPE, cold exposure, respiratory infection. Obviously, any infection, any lung pathology, pre-existing lung pathology contribute to risk factor for forming again HAPE. Okay. Now, here there is sex predilection where male sex is more commonly affected compared to other female counterpart. Why so? Because you see, male are more prone for for respiratory pathology. Why so? They are more prone for COPD or smoking related diseases. That's why they are more common to have this high altitude related pulmonary edema. Okay, so there is pulmonary hypertension, and absence of one pulmonary artery is obviously a risk factor. Now, what will be the feature? Initial feature will be decrease in exercise tolerance, and it is the earliest feature. Later on, patient can develop dry cough and pink for this sputum related symptom. There can be tachypnea, tachycardia, and crackles can be there. Although crackles is not something very mandatory finding that needs to be there to diagnose this is a HAPE. Okay. Now, why it happens? It happens due to hypoxic pulmonary vasoconstriction. And this vasoconstriction, remember, is uneven. So it is very important point for you. This is uneven vasoconstriction, which leads to overperfusion. And pulmonary capillary wedge pressure increases more than 18 mm of mercury. Okay. Now, there is completely failure of the capillary stress, decrease in nitric oxide, which is a vasodilator, by the way, increase in endothelin 1, which is a vasoconstrictor, resulting into features of hypoxic pulmonary vasoconstriction and pulmonary edema. So, how do you investigate? Chest X-ray is one of the easiest tool which can be available at this remote location. So, chest X-ray is better for us. So, as it is a non-cardiogenic, remember it will have no cardiomegaly. Then there will be patchy peripheral opacities, clears rapidly with descent. Okay. So, as you can see here, this part in this chest X-ray, if I zoom this in, so this part in the right side, there you can see some consolidation which is patchy in nature. So, which here is mimicking nothing but ideally pneumonia. Okay. So in this patient, as you can see, actually it is due to high altitude related, and this opacity cleared almost completely in 2 days with descent and supplemental oxygen therapy, so that can be reversed easily. Remember, pulse oximetry is poor predictor of acute mountain sickness, so it is not very important investigation tool for us. ABG is something not very mandatory to check for PO2 level. You can obviously diagnose clinically, and USG is sensitive but not specific something. So obviously X-ray is better choice. Now, how to prevent this? This is the most important need. This is area. If you see the question, most of the question were asked from this topic only this time. So prevention should be remembered by non-pharmacological method and pharmacological method. So what is the best method? Obviously, as ascending rapid ascent is the main risk factor, ascent should be gradual. How gradual? Let's say less than 300 meter per day and sleeping altitude more than 3000 meter. So daily ascent should be less than 300 meter. And after every 1000 meter, there should be 1 day gap for resting. Okay. And obviously, at the meantime, proper hydration should be taken care of. Alcohol and sedative or any other drug which can precipitate such illness should be avoided. Okay. Now, this is a non-pharmacological method to prevent. Now, what are the pharmacological method to prevent? So, prevention and treatment doses differ for it. So AMS prevention or acute mountain sick prevention, acetazolamide is used. It is 125 milligram twice a day. For treatment, it is 250 milligram twice a day. I'll come into how it is used and why it is useful even. Dexamethasone is 8 milligram per day. It is alternative with acetazolamide is contraindicated. Say the patient has any sort of sulfur allergy or patient is CKD, something of an end-stage renal disease when we don't give acetazolamide or avoid in such patient. In such cases, dexamethasone can be given. But remember, it is not for treatment. It will only marks the symptom. Dexamethasone marks symptom, but acetazolamide is the treatment. Okay. So which is the better drug? Obviously, acetazolamide is the better drug. Nifedipine is obviously used. It is used when there is prior history of pulmonary edema, high altitude related pulmonary edema, and again the patient is going for climbing. In such cases, nifedipine is used in 30 milligram twice a day. Even tadalafil can be used. What you need to know? Ginkgo biloba, no role, diuretics are contraindicated, beta agonist is not recommended. So, which one is contraindicated? Diuretic is contraindicated, rather, patient should be kept on proper hydration. Ginkgo biloba is ineffective and inhaled beta agonist have no role in the treatment of it. Okay. Now, this is a very high level table. So, regarding the treatment part, so as you can see, acute mountain sickness can be mild or moderate. Remember, this mild and moderate is very much subjective and not specific for person to person. Okay, so it is very much subjective based on the symptom, what sort of symptom they feel. So obviously, at initial treatment would be discontinuation of ascent and treatment with acetazolamide. Here you can see doses 250 milligram twice a day, whereas 125 milligram twice a day was during prophylaxis. Okay, now if even though there is no treatment available, nothing is helping, descent should be done. Okay. Now, if the symptom is more, in this cases, immediate descent should be done. Okay. If symptom is more, we should go for immediate descent and low flow oxygen if available. Now here acetazolamide and plus minus dexamethasone should be given. All right. And if descent is not available for some any reason or some harsh climatic condition, in such cases, we can go for hyperbaric therapy. Now, what does acetazolamide helps actually? You see, acetazolamide is nothing but carbonic anhydrase inhibitor. Okay. As it is a carbonic anhydrase inhibitor, what does it lead to? It lead to bicarbonate urea. Due to the loss of bicarbonate in the body, there will be metabolic acidosis. Okay. Now, this metabolic acidosis, what will this metabolic acidosis will deal with? It will correct the pH level. As as there is respiratory alkalosis because of CO2 washout in high altitude, because of the ventilatory drive, because of the carotid body sensation, increase in ventilatory drive due to decrease in partial pressure of oxygen, there is respiratory alkalosis, for which pH increases. To maintain this pH, body's response is metabolic acidosis. So, what does this acetazolamide does? Acetazolamide increases the process in which acclimatization helps in, that is, there is increase in metabolic acidosis. So, pH gets balanced, normalized, so that CO2 washout can continue, or there can be increase in ventilatory drive. That's why acetazolamide is used both as prophylaxis and treatment purpose. Can be used both for prophylaxis and treatment, and it is better drug. Remember, remember most importantly, dexamethasone will mark the symptom of nausea, vomiting, and uneasiness. Okay, it will not ease of symptom. It will only the marks. It will only marks the symptom. Okay, so acetazolamide should be given at any cost. Dexamethasone only is never the treatment until and unless there is specific contraindication, say sulfur allergy or secondary ancillary general disease, where we will not prefer giving such drugs. So as you can see in high altitude cerebral edema, which is at the extreme of the spectrum of AMS, so immediate descent or evacuation is required. Administration of oxygen should be done. Here 2 to 4 liter per minute. So there is high flow of oxygen, a little bit of higher flow than the normal flow is required. It's not high flow, but a little bit higher flow. Treatment with dexamethasone and hyperbaric therapy, if descent is not possible, should be done. Now here remember one thing: how much descent? So nothing has been specified. At least, say person was ascending up, and certain point, this person felt ill at this point, at this particular level. So your step should be descend him back to his previous point from which there was symptom onset. Okay. Okay. So then coming to high altitude pulmonary edema, so immediate descent or evacuation, minimization of exertion while patient is kept warm. So oxygen is given more higher dose compared to the HACE or AMS. So here target is to bring oxygen saturation more than 90%. And adjunct therapy of nifedipine or tadalafil, it is preferred only when there is past history of HAPE. Okay. So again, just revise this high yield point. So what is the treatment of AMS? Obviously, stop ascent. We are talking about the mild. Okay. So here we are not going for immediate descent. We are stopping the ascent. And what drug we are giving? We are giving acetazolamide. How much? We are giving acetazolamide at 250 milligram twice a day dose. Then what else we can give? We can give analgesic plus minus supportive care based on the symptom. Then we can sometimes, if symptom is more, we can consider of adding dexamethasone to the treatment regime. What to do in moderate? In case of moderate, when symptom is more, here at this point you plan for descent. If descent is not available, consider hyperbaric oxygen therapy. Oxygen therapy or hyperbaric bag. Not hyperbaric oxygen, actually, here there is need of hyperbaric bag therapy. Oxygen is the primary thing that required during hyperbaric bag chamber. Then, then obviously here acetazolamide plus minus dexamethasone is used. Usually, Usually in mild AMS, dexamethasone are avoided. Okay. So what happens in HACE? HACE, remember here you need to immediately, as it is cerebral edema and patient is going to develop altered mental status and ataxia. So you need to immediately descend the patient. How much? From which the symptom started. Okay. Then oxygen needs to be given at the rate of 2 to 4 liter per minute. Okay. Then here dexamethasone should be given with loading of around 8 milligram loading followed by 4 milligram QID. So dexamethasone 8 mg loading followed by 4 mg QID, and obviously hyperbaric pack if descent is not possible. Regarding HAPE, obviously again here again like HACE, immediately descent should be done. Immediate descent should be done. Now in HAPE also oxygen should be provided at more higher dose around say 4 to 6 liter per minute, or even you can increase the oxygen to have a something of SP to target range of more than 90. Okay. Then what else? What else? You can give nifedipine if there is past history. If there is past history, or you can give tadalafil too. All right. Okay. Now you need to keep the patient obviously warm, minimal exertion, and hyperbaric oxygen. Obviously, here again hyperbaric bag. if descent is not available. Now coming to this hyperbaric wave, very exam favorite image-based question can be asked. Actually, it has been asked in other FMG question prior. So what is it? It is actually portable chamber. Now, as you can see, it stimulates descent by around 2000 meter and it buys time. Remember, it is not a definitive therapy. It's never the definitive therapy. It This is a point from which question can be asked. So it only helps you buying some time. It is never the definitive therapy. So it is useful when descent is delayed. When descent is delayed, it is useful. What is done here, as you can see, it is a cylindrical bag. The weight is usually kept less than 7 kg, it's around 5 to 6 kg, so that mountain climbers can take it to upward, okay, in their bag. So it is around 5 to 6 kg. And it is one-way valve. It is one-way valve. What does it one-way valve do? It doesn't allow carbon dioxide buildup. There is a person with the foot pedal who continuously inflate it to maintain a pressure of 2 Pascal. Okay, maintain a pressure of 2 Pascal. So what it does, it help? Say if someone is at the rate of, at the level of 4000 meter, he will feel pressure of around 2000 meter. So immediate descent thing can be quickly done with the help of this hyperbaric wag. So this is very much useful in the cases of HACE or HAPE. Now coming to other high altitude related problem. So these are the smaller diseases. So in sleep, there can be sleep disorder related to high altitude. There can be periodic breathing. Now question is whether acetazolamide is useful or not. So remember, as acetazolamide causes metabolic acidosis, and it is nothing but helping in acclimatization. Therefore, it is helpful in all the form of high altitude related disease. Okay, so it is acetazolamide is useful. Coming to GI side effect, there can be bloating, there can be flatulence, which is common, but diarrhea is very much uncommon. If there is diarrhea, obviously think of other pathogen, usual pathogen, which can lead to similar symptoms. There can be cough due to cold, dry air, which result with descent. In ocular manifestation, there can be retinal hemorrhage. We have already discussed. It occurs more than 5000 meters. These retinal hemorrhage are usually asymptomatic, but if it involves macula, it may lead to vision loss. Neurologic feature other than this of acute mountain sickness that can be there, there can be high chance of transient ischemic attack, stroke, or seizure. All of those risks increases. Okay. Now, if we check some special important MCQ point, so if the patient is having CAD or coronary artery disease prior, in such cases, treadmill test is necessary if history was there. Okay. If the patient is non-hypertensive, rise should be again transient and usually they are safe. Okay, remember they are safe. If they are safe, they can climb. Asthmatic patient. So asthmatic patient, invariably, strangely, they have better prognosis compared to general population. Why so? Because their lung are habituated to stay in low oxygen setting. So they has been found to have better prognosis and better at higher altitude. Okay. Pregnancy is not completely contraindicated from mountain climbing, but it should be avoided when more than 3000 meter. Okay, it should be avoided more than 3000 meter. Obesity obviously increases the risk of acute mountain sickness, and sickle cell disease may lead to sickle cell crisis, pre-existing sickle cell crisis, even at 2500 meter. That's why a patient with sickle cell disease should avoid mountain climbing. Coming to CKD, avoid acetazolamide if GFR is less than 50. In cirrhotic patient, there will be high risk of encephalopathy, diabetic, obviously continuous glucose monitoring will be preferred. And in malignancy, bleomycin increases the oxygen toxicity. Okay. Now coming to the one important topic for part of completion sake, it is known as Monge's disease. Monge's disease. So it is nothing but a chronic mountain sickness. It is seen in Andes tribe more than the Tibetan tribe. Because in the Tibetan tribe, because of the genetic mutation that we have discussed earlier. So genetic mutation which result into a defect in the HIF2 alpha or hypoxia induction factor 2 alpha because of the mutation in the EPAS1 or EGLN1 mutation. They do not have the symptom like chronic mountain sickness in them, but it is seen in NDS population. What are those? These are excessive erythropoiesis, pulmonary hypertension, and all of this lead to core pulmonary. What is treatment? Obviously, descent is the treatment. In any case, acetazolamide will help because it will promote metabolic acidosis, and phlebotomy. Phlebotomy only when hemoglobin is more and there is symptoms of polycythemia in them. So coming to some last minute revision point, you should remember the pathophysiology is different for acute mountain sickness and pulmonary edema, although cerebral edema and mountain sickness have similar pathophysiology. So in pulmonary edema, there is vasoconstriction, so no inflammation. The question has been asked from this point prior. Pulse oximetry doesn't predict acute mountain sickness. Descent is definitive treatment for all of the cases, and acetazolamide leads to metabolic acidosis and increase in ventilation. So here the question is framed like that: descent versus dexamethasone, which is better? Obviously, descent is better compared to dexamethasone because dexamethasone only marks the symptom. So dexamethasone treats the symptom, not acclimatization. So that's all regarding this topic of this Edison based module. So next we will cover another topic, and in this way we are going to cover complete Edison in small clubbed notes, and I will help you to revise the complete Edison together. So let's study the Edison together.